My standard discussion on that is the reason to treat scoliosis is to keep you in the game of life, the game of whatever it is. Not everybody has to be an organized sports person. I happen to love sports, but I want them active.
Scoliosis often emerges during periods of rapid development, turning what could be a normal growth spurt into a race against time and progression. But the challenge isn't just finding the curve, it's predicting what that curve will do next. This is Charting Pediatrics. To explore the latest in scoliosis care, we are joined by my friend and colleague, Dr. Mark Erickson. Dr. Erickson specializes in orthopedic surgery and is a medical director of our spine center here at Children's Colorado. He is also a professor at the University of Colorado School of Medicine, where he is the fellowship director of the Pediatric Orthopedic Surgery Program. Mark, welcome to the podcast.
Thank you very much. It's delightful to be here.
We are so happy to have you and to talk about this important topic. So let's start with some basics. How do you define scoliosis?
That's a good question. Technically, what we've decided in our research is that 10 degrees measured by a technique we call the Cobb measurement. 10 degrees or more qualifies as scoliosis. Up to 10 degrees we consider to be within the normal spectrum or the normal range. That being said, we don't treat it much until it gets to be 15, 20 degrees, typically, because some of the smaller curves will resolve spontaneously.
And then why is it so important for pediatricians to find this early in the office?
That's also a very good point and critical to the success of what we're going to do. The main reason I would say that is if we catch it early, we can hopefully have a better chance at avoiding surgery and also further progression. We get pretty aggressive with bracing. Some of our data now that we're researching has dropped our bracing numbers even lower. We used to not brace anybody till their curve got to be 25 degrees or more. Now, upper teens, 18 and 20 degree curves will be aggressive, especially if they have a lot of growth remaining. Puts a higher impetus even on earlier notification and identification.
So what are the most common ways that scoliosis can present?
I would say the most common, they almost always occurs in growth spurts. There's a form we call early onset. We used to call it infantile, but it made it simpler. Anybody 10 years of age or less. There's a lot of growth that occurs between 0 and 10, as we all know, seen kids go from toddler size to junior high size or middle school size. And the second one is an adolescent, which is by far the more common. The younger you have it develop, the more rapid the progression can be and the more difficult it can be to manage. So that's mission critical as far as finding that out.
So is this something that parents would notice first, or is it something that's found, say, by the pediatrician or a school sports physical?
I would say number one, for sure, is primary care office and the well child visit. They're strategically placed typically annually. And usually at that age, the kids will have enough growth that you can see changes. And they'll see changes in the trunk. I'd say the second one would be around here in Colorado anyway, the summertime, when people start wearing short sleeve shirts or less layers and you can see the chest wall. And they're developing most classically in the summer when they're in swim trunks or swimsuits. Those would be the most common.
So let's say that a pediatrician is doing a normal well child exam, finds what they are concerned with, maybe a little bit of scoliosis. What's their next step?
That's a really good question and kind of depends on a few variables. If they have access, if they're here and on campus, then they can get an x-ray easily. But I would have a low bar for a referral for that topic, especially if it's just for an x-ray. And then that'll give us an answer to look at and a baseline to work from.
Are there any red flags in either a history or a physical that put you on high alert?
Definitely. From a history, pain is a big variable because we all have back pain. That's meaning all humans. But in kids, if they have back pain, it usually goes away quickly. They're pretty innocuous at events. And then on physical exam, anything out of the normal, especially on the skin or cutaneous exam, if they have any midline defects or hairy patches or clefts or dimpling, those kinds of things. So I always preach sort of a little bit to our trainees that you can't examine the spine with all their clothes on. They need to have a gown so that you can see the skin and the midline structures and understand what's going on in the chest wall.
So, Mark, you and I have been around the block a bit. We've done quite a bit of work together, and there's been this ongoing debate about scoliosis and screening. And are we finally at a safe landing point, or is there still some divergence in opinion?
I think there's still some divergence, but I would say in our meetings, the Spine Society meetings, we just had one of our annual meetings in May, and one of the conclusions at our spine panel was that we perhaps should be more aggressive in smaller curves, 20-degree curves than we used to be, because we have a chance to prevent them from progression, because the bracing technology is so good now. Using CAD/CAM technology, for example, to make a brace that would fit any of our chest walls securely and snugly that previously had to be adjusted a lot. The technology available allows them to make braces, and then that drives compliance, because bracing doesn't work if it's in the closet. And so, and what makes it not be wearable is one of the things we can control is if it's comfortable enough. And so I think the bracing now is better than it has been. And that has allowed us to treat them younger. And so we advocate for that now.
So you brought up imaging, and I think that's another big question area. Who should get imaged? When should they get imaged? How often should they get imaged?
Yeah.
You did talk a little bit about people who happen to be probably close to a major medical center, but what about people who are out in a rural community?
Right.
What happens then?
That's a good question. I have a lot of patient calls and family calls and practitioner calls, which I'm delighted to take, or emails too. For me, it kind of depends on what X-ray capability you have in your facility or near you. Paired with, nowadays too, we have special machines that are way lower dose radiation. Many families, and I probably would drive 50 miles to get that X-ray with a low radiation. That's 7 or 8 times less radiation at least.
Wow.
I probably would for my child. Obviously, that depends on the individual circumstance and weather and all these variables. But if you have some orthopedic office where they have the ability to take these X-rays, then I think it's doable where you are. That can be a conversation now. The challenge for me is when an X-ray comes in and it's, I need more because not, then I got to get another one. Challenge isn't terrible. I'm just thinking about the kids' exposure, and 2 X-rays isn't terrible, but I'd rather have 1 if I could get away with it. So that's a debate. They're not a debate, but a discussion I have typically if they live in Montana and it's an 11-hour drive. I hate for them to come all the way down here and find out that they don't need another X-ray. And we try to manage that accordingly and get it locally if we can.
So from a pediatrician or family medicine doc's point of view, any abnormality that they find on exam, whether it's the skin or the spine, all those kids should get an X-ray.
I believe that's true. And any asymmetry with the forward bend test that you see, those combination of things, I think if any one of those have a significant physical finding, then I would get an X-ray.
And we know that not every spine responds the same way. And we talked a little bit opening up about, what is going to happen to that curve. And if you had a crystal ball, can you kind of tell by looking at a kid who's going to progress, who won't? Where is it mild, minimal, or do you need to rely on X-rays to that?
I'd say a combination, but as experience helps, you get a gut read. I would say especially in the younger crowd, the early onset crowd, where they're smaller children and they have a lot of growth remaining. You can tell by their chest wall contours how much rotation they have in their spine, because the chest wall depicts that for us on exam. In that crowd, for sure, that's an easier thing. In the kids that are in their teenage years, it's harder to predict growth unless you have a lineup of relatives to tell you how tall that family is, for example. So in that age group, I tend to rely more on the X-ray than I do on the smaller children, because it's a lot more severe deformity, the ones that progress in early onset. Those are the kids that it really is a life-shortening disease when you get bad scoliosis as a 4-year-old, for example, in early onset, as opposed to idiopathic. It doesn't shorten their lifespan, but it definitely shortens the quality of life that they have. Difference between the two, and therefore the earlier kids are easier to diagnose clinically.
Is there some statistics on percentages of kids who are idiopathic versus those who are more severe?
The idiopathic is for sure the most dominant. I would say in our busy center of the patients that we see, more than half of them are idiopathic, adolescent idiopathic, which is the most common. In the early onset, idiopathic is also the most common. The other thing that's happening in that group is as genetic diagnoses come up, what used to be idiopathic is no longer has other things attached to it. And so that's another area. And what I love about the early onset kids is I see them for more than a decade, and I get to watch them go to high school and all those kind of things, hopefully. And that's super fun from my perspective. And you get a little bit more clinical experience that way because you have more time to see their growth patterns.
And, it's so frightening for, I think, the child, probably even more than the parent, to hear the word, I think you may have scoliosis, you need to get x-rays.
Right.
I think especially for some of these younger kids and their imaging of themselves, they think, oh my God, I'm going to look like Darth Vader wearing this huge body brace or something. How do you talk parents through the next steps?
That's also a challenge. Requires a chair, meaning you need to take the time. So therefore you have to have the time and plan the time. So we accommodate that by having, as best we can, by having our appointments be such that we'll have that time. I've been fortunate to build into my practice having a PA that works with me closely, and he will help. We ham and egg it, as we call it. If he sees I got a long conversation up, because you can tell. I see the x-ray, and I'm going to need a chair on this one. I try to sit down on all my, but the point of that is, okay, then he'll go manage the next two so that we don't make people wait too long. So that's that. So taking the time. And then really explaining it. I think having electronic record has helped, because I used to have to bring an x-ray in and hold it up. Now I pull it on a computer screen and I show it to them. I give them what's going on. The kids can see it. Parents can see it. I can send it to them in my chart. They can look it up when they get home, because they always have more questions when they get in the car. And then we give them resources to have them help and try to make it group decision-making. That's the best way from my perspective. It's a rare event that we need to decide today that we're going to do a brace, but I'll have the discussion. Say, if you want to think about it, let me know. Here's some resources. If you want to meet again, that's fine. And that allows us the opportunity for them to get their questions answered, which I think is pivotal. Decisions are much better made with everybody having at least similar amounts of information. So we try to pride ourselves in making that happen. That's changed a lot over time, because it's hard to do that right when you come out. I think you kind of learn that along the way, I hope, anyway. So. And that has really helped us to propagate that as a methodology. And it's been pretty successful.
Is there any problem with a child continuing to play sports, whether it's baseball, football, gymnastics, when they have a diagnosis, say, of an idiopathic scoliosis?
My standard discussion on that is the reason to treat scoliosis is to keep you in the game of life. The game of whatever it is. Not everybody has to be an organized sports person. I happen to love sports, but I want them active. As we know, our skeleton and our muscles are designed to be used, and we don't. They atrophy. It doesn't take long to figure that out as you go through decades in life, right? So from my perspective, that's how I approach it with my patients. Say, I want you to be doing your soccer, your volleyball, whatever it is you do, and we will work around that. And so that you'll have the brace off if we're bracing you, for example. If you're having surgery, we'll have it. I love having goals. And with the athletes, I'll say, I'm probably going to ruin one season if we have a surgery, but we'll try to get you back on the next season and figure out how we do that strategically. It gives them a motivation to go do it. And if given that, they usually are pretty amazing at making it happen, which is fun.
So one of the things you talked about earlier is that mild scoliosis would be considered sort of less than a 10-degree curve.
Yeah.
Is that what I heard you say? So can those kids be managed by their pediatrician or family medicine doctor, or does that need to come to more of a specialist?
I think 15 degrees and under, I think is completely reasonable to be managed until it has progression, or if it has progression. Because a certain number of the curves, 15 degrees and under, will resolve spontaneously. And when in an early onset forms, more than that. Early onset forms, the 15 and 20, even 25 degree curves, half of them will resolve. Unfortunately, the part that don't resolve have a rather escalating, rapidly progressing track. So I'd say yes to your question. 15 and under is completely reasonable to manage, always using the caveat that you can send any time or call or text or whatever works best for you, and then we can discuss the best option from my perspective. And I have many that we manage that way.
So how do you make the decision to escalate care? It sounds like maybe you go from watching to x-rays. When do you make the decision for a brace?
Those are important points. The two most important variables for progression risk are growth remaining, which isn't just age. In girls, it's menarchal status. 2 to 3 years after most women start menarche, they stop growing. Growth's a huge variable in curve progression. If you're done growing and your curve's less than 30 degrees, it's a non-worry because it won't likely progress. And the other is curve size. So if you have both of those, then escalation's probably going to happen. If you have a 20 degree, 25 degree curve and 4 years of growth remaining, we'll probably need to escalate to at least bracing. If you have 0, you're skeletally mature and your curve's less than 20 degrees, probably not to worry. The other end of the spectrum is a little bit more intense. If you have a curve, 10 years of growth remaining or 8 years of growth remaining and a smaller curve, I still watch those like a hawk because they have so much time left in their growth pattern.
And what's the success rate that you have of bracing? I mean, can you tell the kids, hey, if you get better, you can ditch your brace?
Yeah, I think that's an interesting question. I think it's not me that has success with bracing. Bracing success, we've even have some level 1 evidence now that it's 100% dependent on compliance. It only works if you wear it. And one of the studies that we've done over time is, verbal compliance. If I talk to you and say you wear it, a lot of people say, oh, yeah, I'm wearing the brace a lot. Now that question doesn't come up. And I like that because I don't have to, corner someone. I get a report card. We have a button sensor in every brace. It's about the size of a battery button, a little bit like a quarter. And it's a temperature sensor. So I get a printout when they come in of how many hours they've worn it since I saw them last, on average per day. So the conversation, instead of how much you're wearing the brace, is now it looks like you're wearing the brace about 14 hours a day, right? What we prescribe, that's perfect, and I appreciate that. That's a totally different conversation. And the teenagers will respond to that differently then. And looks like we're having some trouble telling what the trouble is and how can I help you with that? That's really ramped up our compliance because that's the key to success. And I thank them for it all the time because all I can do is ask. And I've never worn a brace and I've never been a teenage girl. So I talk to lots and listen to lots, and I think I've learned so much from them.
That's fabulous. It's kind of like having an air tag for your kid. Now you sort of know when you've been wearing your brace.
Where'd you say you were?
Exactly. I know where that brace was. Are there any misconceptions about scoliosis that you've heard over the years that you'd love to clarify?
I think one misconception is that it's a big source of back pain. If I see scoliosis with back pain, it raises flags that I have to find out another cause. That's a rule-out diagnosis, a diagnosis of exclusion to blame it on the scoliosis because that's a trap. So if I see back pain, I'm going to investigate clinically, thorough exam to make sure that I have a really good solid. And it's a quick trip to an MRI if I don't have answers because I have to make sure there's not something else going on. So that's the number one by far. The second one would be that it takes you out of sports. There's some sports if somebody has scoliosis surgery, a collision sport like football. If they have a spine surgery and getting back to football, I love football, but getting back to a collision activity, it stresses me out to think that I have people that do it. I just advise people not to, but I don't advise it. And then the other one's gymnastics, where they have to be sort of hypermobile to do the incredible tricks that they do in that sport. And so any surgery we do on the spine can minimize that ability or make it difficult for them to do the heavy duty tricks. Outside of that, I don't restrict sports hardly at all. So that's a myth that from my perspective, most of the kids get back to full activities and full sports and even through college.
So far, just to recap, we've talked about kids with a less than 15% curve. We're going to do some watchful waiting on.
Yep.
For the kids who are beyond that, we're going to do the brace that has the secret sauce inside of it that we know when they're wearing it. And then I guess the next phase would be surgery. And then
Yeah.
how do you decide how you make that leap from bracing to surgery?
Very good question and very thoughtful process that we go through. Some of them become no-brainers. They come in, their curve went from 15 to 30 to 50. You have to do something. Some of them will, just like some kids will be late bloomers, seemingly stalling or finishing out their growth and then have a late spurt and then it progresses. Different conversations with different. So I always say that I want to follow them till they're done with high school. Virtually all women are done growing by the end of high school. Not all the guys are, but I follow them through high school. And at that point, if it looks like it's stable, then that'll allow us to then decide what we're going to do next. But I'd say the conversations where it trips to surgery are in that mode. I'd say at least 75% of the time in my practice, the pictures tell the story. Because also what I can do on Epic that I didn't use to do with electronic record is I can on one computer screen pull up 4 years worth of x-rays next to each other, each with, because we have big screens, each with a, easy to see across the room, and you can see the progression naturally. And it usually tells its own story, meaning it looks like it's going to keep going and we probably need to stop it or do something about it, which leads to that next level conversation. The hardest ones for me are when the first time I meet somebody, I know they need surgery because I don't like that conversation. I don't, not that I don't like the conversation. It's just super difficult for everybody to wrap their arms around it. Some of them come in and I'm the third opinion. They know they need surgery. That's a different story. I'm talking about here's the curve. I don't think bracing is a good idea. The curve's too big. We need to go to surgery. Happens, but hopefully not as often as we used to see it that way.
So we're not going to get into all the specifics of spine surgery. That would be a whole nother podcast. But can you just give us a little glimpse into maybe how surgery or goals have changed? Like, I think when I trained, everybody got a straight rod in their back. I think things are different now, but can you give us a little snippet of what it looks like?
Absolutely. I'd say 2 general categories. There's a fusion category, or 3 general categories. Fusion category, fusionless surgery, which is tethering and things that we're trying to do to figure out. That one's still on the cusp and don't have as long a term of data. And then there's growth, what we call growth friendly. I'm not sure how friendly it is, but in the little 5-year-olds, we don't do fusions very often. So we'll try to get them to maintain the control of the spine with some growth friendly, instrumentation friendly, meaning it allows them to continue to grow. Because the fusion by principle takes away the growth on the other end of the spectrum. So we try to reserve fusion for kids that are close enough to done growing that we won't create a big disproportion between their trunk size and their legs. And so those are the 3 big categories.
So it sounds like it's a little bit more motion preserving if you have that more flexible, whatever you would call that surgery.
The data has shown us over and over again that if possible, fusing less levels is better because you maintain more motion into your adult years. And that leads to less degenerative issues, especially in the lower lumbar spine. So we try to do as little levels of fusion, as small a number of levels of fusion as possible. That's what brought in the middle technology, the tethering, and trying to mitigate that and figure out where that's going to fit.
So let's look into the future just a bit. Any hot new research about to come out, new techniques, new ideas?
Lots. I think the tethering is finding its plane, so to speak, where it's going to help. We know they break a lot. That's the challenge. And when they break, sometimes it's okay, sometimes it's not, and we need to either go to another tether or convert it to a fusion. So we haven't balanced that out. That I think will be figured out in the next 5 years or so. And then the advent of technology. So AI and robotics and navigation is one of my very keen interests. One of the quests that I've always had is perfect surgery. Who wouldn't want that? Myself included. As humans, I think if that ever happens, I'll probably just have to keep driving west and go live in the mountains forever because I don't think it'll be repeatable, right? But the closer you get, the better. And I think the navigation, robotics, and using artificial intelligence helps what you just discussed. We used to use a straight rod. We don't do that anymore. We know there's contours that need to be in the spine, and especially in the sagittal or side plane, and we can contour those and make rods specifically with that in mind, so we can get people to an appropriate posture, which bodes well for their long-term spine health. So all of those things are on the cusp right now. The robotics is going into its second generation in navigation as well. And AI is helping us to take large language models and help us find out across the masses of age groups what's the best alignment rather than straight. And that's really an amazing advance to be able to dial that in, so to speak, in the operating room.
Mark, what role do schools play in scoliosis screening?
That's a great question. That's dependent. There's pockets within the United States now. It used to be, and it was a standard of having school screening, usually in grade school for the girls, especially, was that when they had their first growth spurt, where we'd have them do their forward testing. But we had school nurses in lots of schools that were running that. Over the last, I'd say, my career, 20 years plus, that's phased out a lot, meaning we don't have nurses in every school anymore, and we don't have that ability to do that anymore. And so therefore, it's, I think, falling in the laps of the pediatricians, which I think it's working well from my perspective. The way I would judge that is, am I seeing people coming in and it's way too late? Rarely, very rarely. And usually there's an extenuating circumstance that isn't related to availability. So I find that even in our rural families, they get good care, very good care, and very attentive to detail. It's just not in the school setting as much as it used to be.
Do you think that there's any kids that we miss who don't get screened either in school, sports, or their primary care medical home?
Rare these days, but it happens. And when it happens, it's challenging because they come in with bigger curves. We have to do more aggressive maneuvers to get what we want for success. That used to happen, I would say, weekly, if not bi-weekly. Now it's a couple times a year, maybe every 2 or 3 months. We'll have that, something like, we review all of our cases on a month basis, and so we know when that happens. And when it does, we kind of look into where that came from. I would say now when it happens, it's somebody that was more transitory home. They moved a lot and didn't have a 4-year attachment or 5-year attachment to their primary care doctor in their communities, and maybe had a couple of annual visits missed. That's more the story now, not regular like it used to be.
Well, Mark, thank you so much for spending some time with us, sharing your vast fund of knowledge on scoliosis. I know I've learned so much. I'm hoping that all of the audience feels the same way. And to all of you listening, thank you. And until next time, keep on keeping kids safe out there.